The next talk will be by Dr. Sumit Ray. Which interventions make a difference in sepsis?
Oh, the other one.
I'm sorry?
Which interventions? Yeah. He's put the wrong lecture. That's not the lecture. The other one. Good afternoon. The nature of the beast is that we'll be repeating ourselves, all of us, with slight different kind of emphasis on the second one. So Srinivas was, I think, tired of me and all of us saying that nothing works, this doesn't work, that doesn't work in sepsis. So what the hell works is the big question. So before we go to that, we need to know surely what causes harm, right? And for sure, or does not have any benefit and are very expensive therapies. For sure, high dose steroids cause harm, we know that. For sure, anti-tumor necrosis factor alpha, TNF alpha, does not cause any benefit, and anti-inflammatory therapies like this do not cause any benefit and they are expensive. Talactoferrin was tried, anti-inflammatory, doesn't work. Erythroran toll-like receptor antagonist did not work. Monoclonal anti-endotoxin antibodies, Angus's study did not work. Polymyxin B, very exciting stuff for most of us, wanted to do something sexy and put in some interesting stuff on the dialysis machine. And well, what do the trials say? This trial, the small trial called the UFUS trial, 64 patients only, they showed a survival benefit, but actually, sorry. Okay. Can you get this for me, please? This one, yeah. This one, yeah. Right. Thank you. Yeah. Right. So this is the propensity matched cohort analysis of the polymyxin B or toramyxin as we know it. 1180 patients from Japan, no benefit. Then this study by Didier Pine from France and Europe, basically looking again at the polymyxin B and did not show any benefit. Actually, there was a trend towards higher mortality with the polymyxin B in abdominal sepsis, and he says in that conclusion, in the absence of any positive signal in this RCT, pleads against the use of polymyxin membranes. So because polymyxin did not work, we had cytokine removal systems coupled with plasma filtration. It's called the plasma coupled plasma filtration adsorption techniques like cytosorb, etc. Again, this study is planned 330 patients, ended up with about 184 patients, no difference in survival between the two groups. But they said that in the subgroup analysis where the CPFA dose was more than 0.18 liters per kg per day, there was a trend towards improved survival. So they are planning a larger trial now, which they have given the trial protocol for using the plasma adsorption, or it is called the ROMPA study. Okay. Now all of us know that activated protein C doesn't work. Antithrombin 3, large trial of almost 2,300 patients, no difference in mortality, higher bleeding incidence. Cochrane review shows that there was no difference in mortality for antithrombin 3, and actually bleeding events were more. Thrombomodulin is the new player on the block. It's recombinant human thrombomodulin ART-123. It acts by reducing thrombin-mediated clotting, enhancing protein C, has anti-inflammatory properties, and supposedly has endothelial stabilizing properties also. And it was used 2 trials, both small trials. This one did not show any mortality benefit, but they did multiple subgroup analysis to try to prove its superiority. Significant conflict of interest in this study. This one, again, a trial of thrombomodulin, 68 patients, basically a propensity matched cohort, retrospective analysis, and the board waived the need for informed consent for this. Okay, and again, huge conflict of interest. They showed This is a small study, showed mortality benefit, but there's a larger trial going on at this point of time. Heparin, no individual trials did not show significant mortality benefit, so they did meta-analysis. The Canadian trials group did the meta-analysis, heparin versus usual care or placebo, and there was a trend towards improved survival in sepsis patients. But there is a trial right now going on. Anand Kumar et al. Are doing that trial. It's a pretty long trial that is planned. So let us see what happens. Unlikely, I think, to benefit. So what does the guideline, surviving sepsis guideline say? Blood purification, we make no recommendations for anticoagulant therapy, antithrombin 3 not to be used, against the use. Okay, for thrombomodulin and heparin, the jury is still out for them. Immunoglobulins, multiple studies, small studies showed some benefit, but the Cochrane review looking at trials which had less propensity for bias, low risk of bias, showed no difference for all forms of IVIG for mortality benefit in sepsis. Okay. But still, if you see this ANZIX data from 2000 to 2012, 35% mortality in 2000, which is the time of the EGDT trial, which had 46% mortality. The mortality in 2012 has reduced in sepsis to 18.4, and in septic shock from 40, which is the EGDT trial, 46%. So that was not actually very different from what they were getting in Australia and New Zealand too. Okay, at that point of time, the mortality is down to 22%, 45% relative risk reduction. There's significant difference in mortality in the last 12 years that they have studied. And this is true if you collect data for your own hospital from early 2000s to now, like we have in Gangaram. Pre-2009, our earliest data is about 2007-8 for the kind of mortality. Our mortality has dramatically come down. And it's true, it's not trying to promote Gangaram Hospital, but it would be true of every one of you. If you look at your hospital, your mortality from septic shock would have come down. So something is surely working then. Okay? It may not be these expensive therapies and sexy new stuff, but there is something working. And what is it? In the real life scenario, what is working? So one of, as Dr. Ramesh Venkatraman showed, the resuscitation, the surviving sepsis guideline, 30 ml of fluid, let us look at it. Resuscitation to normalize lactate, these are part of the initial resuscitation. So all of us are going to go through this, you have to sit through this a little bit again, all the three trials, Arise, Process and Promise, but a slightly different take. Huh? I can show you the dates. Okay. So quick look at, I made a table of this. I made the desperate effort to make a table, though there is a patient level meta-analysis also. 90-day mortality, EGDT group usual, all three trials, all of you know, no difference in mortality. These were the Apache scores. The IV fluids given were much more in the EGDT group. In all the trials, the CVP catheters put in were much more. Arterial catheters were much more in the EGDT group. Vasopressor use was higher. Dobutamine use was higher, though there was no difference in mechanical ventilation and renal replacement therapy. This is the patient level meta-analysis. So March 21st, Ramesh, Suresh, sorry. So okay, so primary outcome, no difference in mortality, respiratory support or renal support in the groups. But as I said, the devil is in the detail. And all of us have emphasized parts of it, that all these patients in both the arms got about 30 ml per kg of fluid. Actually, the fluid balance in the two arms at 72 hours was similar, the amount of fluid that they got. Antibiotics pre-randomization, this much, all of the equal amount of antibiotics we spoke about. Mechanical ventilation, no difference. RRT, no difference. And actually, interestingly, even in the usual care, the CVP at 6 hours in the usual care group was exactly the same. In this study did not have that. Arise and Promise had exactly the same CVP as the EGDT group. Okay, so and also the lactate, the lactate pre-randomization levels, and at 6 hours was measured in these two trials, and there was a trend towards reduction. And all these trials actually in the usual care group looked at the lactates too, even in the usual care group. Okay. And that's the patient level meta-analysis, shows the same thing. I won't go into the details, it's exactly the same. So actually the surviving sepsis campaign bundles, the first 3 hours bundles was achieved pre-randomization. And is that probably what caused no difference in mortality? This study, time to treatment and mortality, which Ramesh also showed. So if the bundle was completed within 3 hours, most of the bundle, 3-hour bundle was completed, the median time to completion was 1.3 hours in New York hospitals, almost 50,000 patients in 150 hospitals. The bundle compliance rate was 82.5, which is really good, okay? The median time to antibiotic was 0.95 hours, okay, less than 1 hour. And the median time to completion of the initial fluid challenge was 3 hours, median time, okay? And as Dr. Venkatraman showed, that there was what it shows is that for every hour of delay in completing bundle, there was a mortality increase. And if you compared less than 3 hours versus 3 to 12 hours, the difference was even more, obviously more significant. True of antibiotics too. For IV fluids, Dr. Venkatraman showed that hourly of completion of the IV fluid bundle did not show a difference, but they did a sub-analysis where they found that if they completed the bundle of fluid resuscitation within 6 hours, the initial fluid within 6 hours versus 6 to 24 hours, there was a difference in mortality. So even if it is not 3 hours, if they've completed that 30 ml fluid resuscitation within 6 hours versus 6 to 24 hours, there was a difference in mortality. Now this one again from the United States, they looked at 3 cohorts. Cohort 1, 5 tertiary hospitals, 6 community hospitals, 2012, 2014 this cohort, and 2015, and they were looking at the 3-hour bundle implementation, blood cultures before antibiotics, IV antibiotics before 3 hours, lactate ordered, lactate result within 90 minutes, and 30 ml crystalloids initiated 30 minutes from time 0, initiated, okay? And they found that in all the 3 cohorts, there was those where bundle compliance was much lower, but those who were bundle compliant survived more, and actually the costs were lower in the bundle compliant rather than the non-bundle compliant patient groups. And this one has come just, I think, yesterday. Basically, just a graph of the New York State data from 2014 to 16, the quarterly increase in protocol initiation and protocol completion has been steadily increasing, and the mortality has steadily decreased from 30.2 to 25%. So as you can see, from 40% in 2000 mortality for septic shock severe sepsis to down to 25% now, there is a steady decline, and there is, as you can see in the whole of New York State, as the protocol implementation for the 3-hour bundle goes up, the mortality goes down. There may be questions about certain elements of the bundle, nobody doubts it, but the real life scenario, not randomized control trial scenario, there is an improvement in survival with the implementation of the bundles. Fluid therapy we spoke about, but also more importantly, probably when to use, and that has been the discussion that we had with Dr. Rami Raj Gopal, also is that there is a rescue. There's a 4 phases of fluid intervention, intravenous fluid therapy, which came a beautiful article in British Journal of Anesthesia by Hoste et al., which looked at the initial phase, the life-saving phase, where you give within minutes to hours, where you give rapid boluses, optimization, which is for organ rescue, optimize and maintain tissue perfusion for the first few hours, stabilization, organ support, aim for 0 or negative fluid balance, and I'll come to that. It's over days, and recovery is over days to weeks. And is there actually evidence for that? This is the beautiful diagram that they grew: rescue, optimization, stabilization, and de-escalation or de-resuscitation. So is there evidence for that? So this study came from, just published this year, audit of 738 ICUs, 84 countries, patients of sepsis in 2 days, and they looked at patients with different quartiles of fluid, 72 hours of fluid balance. The higher the quartile, the more the positive fluid balance, and they found that the mechanical ventilation and hemodialysis rate in the first 24 hours, there was a increased number of patients who had mechanical ventilation and hemodialysis and hemofiltration in the 4th quartile as compared to the 1st quartile. Cumulative fluid balance at 24 hours did not show any difference in mortality if you looked at mortality, but cumulative fluid balance at 72 hours showed a significant increase in mortality in those who had more fluid in both the septic shock and the non-septic shock patients. And as I said, not at 24 hours, so initially giving fluids probably is of benefit. Long term, obviously, if you have positive balance, it is counterproductive. This article comes from Intensive Care Medicine, looked at the database of almost 23,000 patients and looked at day 1 fluid categories, 1 liter wide. That means from 1 to 2 liters, 2 to 3, 3 to 4, till up to more than 9 liters. And they looked at what they call low volume resuscitation, which was less than 5 liters a day, was associated with a small but significant difference in decrease in mortality for every liter that you give from 1 to 5 liters. But above 5 liters, when you are giving high volume resuscitation, the mortality increased for every liter that you gave extra. So between 1 and 5 liters, there is a slight decreasing trend in mortality, but as you gave more beyond 5 liters a day, the mortality increased. I think kind of a balance of what we do in real life. I'm sure Dr. Rami Rajgopal would have some opinion on that. Now, positive and negative fluid balance may be associated, both may be associated with reduced long-term survival. It has just come online, it has not yet been published online. They looked at fluid balance, negative is 0, less than 0% difference, even is 0 to 5%, more than, and positive is more than 5% positive balance. And they looked at all the subjects in this database propensity matched cohort, and they found that for positive fluid balance, there was an increased mortality from short-term and long-term mortality up to day 11 and up to 1 year. But for negative balance, there was actually short-term mortality was less, but long-term mortality from about 88 days onwards, 90 days onwards, was higher than the even balance. So keeping them too negative may be harmful, as we have discussed before also, but positive balance, yes, surely harmful over beyond 72 hours. Vasoactive agents, Dr. Venkatraman spoke about it. My only take is yes, norepinephrine, surely the first drug of choice in septic shock. This trial, the VAST trial, low dose vasopressin reducing mortality did not reduce mortality over norepinephrine. There are questions about this trial surely, but actually it reduced mortality in the less severe septic shock for some reason. And that's why the recommendations were very doubtful till then. But they surely reduce the dose of norepinephrine, which is a no-brainer because it works from a different, on the different receptor from adrenaline compared to, so norepinephrine with vasopressin would reduce the dose of norepinephrine. But this trial called the VANISH trial, which also looked at norepinephrine versus vasopressin, no difference in mortality, just 100 patients in each arm. There were four groups, sorry. No difference in renal failure rates, but the use of renal replacement therapy in the vasopressin group was less because there was higher urine output in these patients in the vasopressin group, and the vasopressin spared the total dose of norepinephrine required to maintain blood pressure. Probably adding norepinephrine to vasopressin, probably better combination than adding the second drug adrenaline. Probably more and more use of vasopressin you will see in the near future, and also the dose of vasopressin that they used was higher in this study than before. All the big daddies of critical care wrote this paper called Sepsis, a Roadmap for Future Research in Lancet 2015. All of those who have done all the anti-inflammatory studies, etc., who made their careers based on that, found that there is not going to be any magic bullets, and they were focusing actually on immunotherapy, actually boosting the immunity in subset of patients who had an anti-inflammatory response. We are finding it more and more, our understanding is improving that sepsis behaves differently in different patients. Some patients have a predominant pro-inflammatory response initially and then anti-inflammatory response. Some have a mixed response, so there are different subsets of patients who respond differently to the insult of infection, and they have to be treated differently. The survival benefit that has happened is because of early resuscitation, and particularly among the young patients. The elderly and those with comorbidities tend to have a predominant, sometimes anti-inflammatory response, which does not augur well for just with early resuscitation. Maybe we require something else. Maybe we need to individualize care, as Ramesh Venkatraman said, in that subset of patients, but early resuscitation may be an important part for the young and the pro-inflammatory. And what else they are looking at in the future is endothelial, basically damage to the endothelium that sepsis causes. As I showed you in my slide on fluids, that the endothelial damage causes a leakiness, which if that leakiness is stopped, the question about dengue also is that if we can stop the leakiness of the endothelium, probably that is the site of action that we would be looking at the future. So what's working at sepsis at this present moment in the real world scenario? Early resuscitation, maybe including lactate clearance, not sure, but early first few hours. Early appropriate antibiotics, SCVO2 not, but just fluids according to the perfusion. Lactate may be added to it, and early antibiotics. Appropriate choice of fluids, obviously, that's what we have learned over the years. Appropriate choice of vasopressors, combining it clinically better now than we were doing earlier. Clinical judgment always is important. So the queen is dead, and this is the new queen probably till we bring it down. I am an anti-monarchist, so I'm sure in the near future we'll bring this down also, but there is still, I think this is at this moment which is working. Thank you so much.